I'm Michael Morrisitz. I'm the Patient Education Manager at Fight CRC. I'd like to thank you for those of you who are returning to come see us again and those of you who are new to our webinar series here. We've been doing access to screening and treatment options in colorectal cancer. And today we are going to be addressing access to clinical trials and enrollment barriers in unique populations. So this has been something that we find is a really important subject to talk about in our communities, especially considering the diversity of our communities and what it really takes to look at each one individually for their specific and unique needs. We have some amazing panelists today, and we're really excited. So I don't want to waste any more of your time because they have so much information to get to today that's going to be really amazing. So let me just go through my introduction, give you a little background on who's going to be speaking today, and then let them share their expertise with all of you. So if you have questions, please insert those questions either in the chat or in the Q&A option that you have at the bottom of your Zoom menu. We'll be happy to have our panelists get to as many questions as possible. If we're not able to get to all of them before the end of our time, please still enter them in. We can always follow up afterwards with the presenters and get your questions answered. This webinar will also be archived at fightcrc.org along with the other webinars in this series and all of our other webinars that we've done. So please head on over to fightcrc.org when you get a chance and check out some of the other great work that we've done with other great presenters. And then also feel free to tweet along using the hashtag CRCwebinar. Also, we recently redesigned our whole menu on our website as well as our resource library. So while you're at fightcrc.org, go ahead and check out those resources for a lot of other options for seeing how we get information out to the colorectal cancer community, including podcasts, blogs, Q&A interviews, you name it. Go ahead and go check that out as well. And then, of course, as the disclaimer, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. And Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. Okay, so your first presenter today is going to be Dr. Edith Mitchell. She's a board certified in internal medicine and medical oncology and is a clinical professor in the Department of Medicine and Medical Oncology at Sidney Kimmel Medical College at Thomas Jefferson University, and associate director for diversity programs and director of the Center to Eliminate Cancer Disparities for the Sidney Kimmel Cancer Center at Thomas Jefferson University. Dr. Mitchell has spent her medical career helping individuals in medically underserved areas to realize that simple changes in lifestyle can have a dramatic impact on cancer care. Through her work, Dr. Mitchell has demonstrated the importance of community service and outreach, especially to those individuals who may not have the means to seek out more conventional medical advice. Next, we will have Wyatt Pickner, who's an enrolled member of the Crow Creek Sioux tribe in South Dakota. He received his undergraduate degree in American Indian Studies and Health Sciences from the University of South Dakota and earned an MPH in Community-Oriented Public Health Practice from the University of Washington. He has a decade of experience working with tribes, tribal organizations, and American Indian serving organizations at local, regional, and national levels on research projects, capacity building, training, and community engagement. Mr. Pickner is currently the research manager at the American Indian Cancer Foundation. In this role, he works with tribal communities to design and implement research projects that assess the burden of cancer and potential contributing factors with the aim to identify culturally relevant solutions. And then we will have Dr. Amelie Ramirez, who is an internationally recognized health disparities researcher at UT Health San Antonio, where she is founding chair and professor of population health sciences and director of the Institute for Health Promotion Research. She has 30 years of experience conducting behavioral and communications projects to reduce cancer, increase screening and clinical trial participation, and improve healthy lifestyles to reduce obesity and diabetes among US Latinos. Dr. Ramirez also leads the Salud America Communication Program for Health Equity for Latino Children and Families. All right, wow. Great group. Thank you all for being here today. We're really excited to have you. And we'll start off today with Dr. Mitchell's presentation.
Okay, thank you so much. And thank you for having me as a part of the work that we do. And thank you for allowing me to share in this program today. Dr. Ramirez and I have worked together for so many years, and it is always a pleasure and a privilege to work with you and to share another opportunity to work together, Dr. Ramirez. So thanks to the group for being here today. And thank you for allowing me to share this with you. So I will give a somewhat historical perspective, but also look at some of the precision oncology and the disparities that occurs in individuals, both in terms of prevention of colorectal cancer, but also in its treatment. So I'm happy to be here. The poet James Baldwin said, "Know from whence you came. If you know whence you came, there are absolutely no limitations to where you can go." And that is a part of what we're doing with disparities now. Yes, we've come a long way, but we've got a long way to go. So we always have to reach back and understand what is going on now and what has happened in the past, but that allows us to plan and look for the future. So data from the National Cancer um, Institute, as well as the American Cancer Society, has shown that non-Hispanic Black males have the highest cancer incidence and mortality rate compared to other racial and ethnic groups. And non-Hispanic white females have the highest cancer incidence rates, but non-Hispanic Black females have the highest death rate. So we really need to understand these data, and that allows us to plan for the future and where we go from here. The trends in the cancer incidence rates among males has been reported over a long period of time, and since 1975, noticed that colorectal cancer incidence rates increased for a while and then have declined really over the last 3 decades. The same is true for females. If you look at colorectal cancer incidence rates, they increased early on, but since about 2005, there has been a continuous decline. Yet, for certain racial and ethnic groups, and specifically African Americans, Latino or Hispanic patients, as well as American Indian and Native Americans, as well as Native Alaskans, there has been a decrease. But the gap still is present among those disparate communities. Dr. Harold Friedman said that yes, there is the gene environment, and historically, the gene environment is very important in terms of incidence and mortality from cancer. Yet, the gene environment can be influenced by a number of factors, including culture, social justice, poverty, and low socioeconomic status. And all of these can influence the gene environment. And therefore, if we're going to be successful in eliminating the high mortality rates, we must start from prevention all the way through diagnosis and treatment, and then survivorship. So we've got to look at all aspects and the continuum of the cancer processes. So we've got to look at everything. Now, one of the areas that really is important, and that is the rationale for workforce diversity. Note that for all practicing clinicians in the United States, AAMC has reported that there have been few changes in the number of Latino or Hispanic physicians, and the same is true for African Americans. Note for African Americans in green, there is about a 5% of all practicing clinicians are African American. And for Hispanic physicians, again, somewhere about 5%, but this is increasing. For the African Americans, it's actually decreased, and current percentages are about 4.8%. So we really need to increase the number of physicians who understand the communities, understand the facts that are related to those communities, and who understands the processes that are successful in the community. So we need to reach back. The ACCGME, our American Council for Accreditation of Medical Education, which all of the practicing physicians in the United States have gone through in some process at some time. And ACGME has said we've got to look at the diversity, the equity and outcomes, the inclusion. And the first thing we need to do is that as far as medical education, we need to acknowledge and contextualize the issue, then accept it. So we've got to make sure that we know what's important and that we accept it, and that we design strategies that will focus on the fact that equity in healthcare matters. ACGME has also said that we've got to use our resources to develop innovative strategies. And once we do that, we've got to implement those strategies and continuously assess and understand what we're doing. So increasing the workforce diversity is very important. And this cartoon conceptualizes that. Notice that there's an apple tree. It's bending in the direction of one person and away from the other. And then we can talk about equality, where we give everybody a ladder. But note that the tree is bent and there are no apples growing, or very few on this side. So it leaves someone and a group of people still having difficulty assessing the apples. We say equity. Well, these people over here are too far, and let's give them a taller ladder. But since there are fewer apples on this side of the tree, there is still inequity. What we really need is justice. Prop up this tree so it's not bending away from a group or a community, and that allows more sun and nutrients, and therefore more apples on this tree. So we've got to look at justice and making sure that structural racism and other factors are not causing inequity in healthcare delivery. So we've got to do better. So what are some of these disparities that cause that tree to bend away from certain communities, certain individuals? There can be implicit and explicit bias. And there is what I describe as institutional structural racism. And we've got to get rid of that. There are a lower number of minority professionals. I've said that and explained. And we've got to give research opportunities to all populations. And we can't have that tree bending away from certain populations. We've got to make sure that everybody has justice and access. there is a lower comprehension in some communities, so that with more individuals participating and collaborating together, we can provide information to populations. But not only our populations, we've got to do that for all of the healthcare, so that all healthcare providers are giving justice in terms of clinical research, education to patients and populations working with people. There are also the cost of care challenges, out of pocket cost, and it's really important that we provide access to our patients, so that out of pocket costs are a part of what we do in allowing patients the opportunities for clinical trials. There are the social determinants of healthcare, with healthcare deserts in certain areas, especially where there has been redlining and racism in housing purchases. There is no access to healthcare in those communities, lack of access of drugstores, and lack of access of supermarkets, where we tell our patients, eat fresh fruits and vegetables, but they live in a desert where there are no opportunities for fresh food. And the best opportunities for food to purchase are with the fast food industries, where they are on every corner. So we've got to fix the opportunities within communities and make sure we understand from our communities or from our patients what the areas of access and what are the social determinants of health that affect their well-being. So this year, 2021, these are the estimates from the American Cancer Society on people and the incidence of cancers. For gastrointestinal cancers, not only are there differences in colorectal, but patients who have a high risk of colorectal cancer also have a high risk of other gastrointestinal malignancies. And for all of these cancers, the receipt of surgery at an early stage of the disease is the greatest influence on overall survival. So we need to screen earlier, make sure that those individuals who have positive screens have access to follow up, and ultimately surgical care and appropriate surgical care has made the biggest difference in terms of decreasing mortality. So for colorectal cancer, just a few facts. Blacks have the highest incidence and death rates for colorectal cancer, whereas Hispanics and Asian Pacific Islanders have the lowest rates, but there still can be differences. Blacks have a distribution of colorectal cancer that favors metastatic disease at the time of diagnosis. And disparities in incidence and mortality can be attributed largely to social determinants of health, and that includes access to healthcare, access to surgical centers. There are studies that have shown a higher frequency of KRAS mutations in tumors, increasing the aggressiveness of the colorectal cancer in Blacks, and Black patients are more likely to be diagnosed at an earlier age with more advanced tumors at the time of diagnosis, and a much more aggressive tumor with poorly differentiated tumors having a higher propensity. These are just some differences that have been described. These are from the National Cancer Institute. And again, note that there is a higher incidence rate in African Americans when compared to non-Hispanic whites, and differences in overall survival And there have been some differences that I mentioned, that tumors occur more frequently on the right side of the colon, and there are therefore some genomic differences. However, when one evaluates the number of African American patients who have genomic profiling of their tumor, it's less. So we've got to make sure that patients have access at least to the standards that we know make a difference. So increased genomic profiling of tumors and increased access to the African American patients, just for things that we already know, BRAF, extended RAS, the right-sidedness, and there are other markers that are emerging and in clinical trials. So therefore, we've got to make sure that our patients have justice in access to available data and markers now. And these are the things that influence the overall choice of treatment in colorectal cancer. So we have all of these. And yet, when you evaluate the number of patients who are African American or for other disparate groups, what we have are differences in access to the genomic profiling of patients, and therefore less information about treatment choices. Another area that where there's a lot of research now is regarding the age at presentation. Note that for patients 50 or more in their age, that the incidence rates are decreasing. Yet for individuals aged 20 to 49, there is increase, and it's estimated that for 2021, 12% of all colorectal cancers will be in this group. And therefore, we need to make sure that all individuals have access to screening starting at least at age 45, but this could be different for individuals who may have increased risk factors, including a family history of colorectal or other GI malignancies. We talk about just colorectal cancer, but as I have emphasized, other GI malignancies can increase the risk for colorectal cancer. So another area that is being investigated now in certain communities are patient navigators. And these are individuals who are not clinically trained, but know their communities and have influence in the community, and who can therefore collaborate with us in terms of providing some of the information that I discussed, and to address the social determinants of health and the influence, and therefore making these available. This is our plan at the Sid and Kimmel Cancer Center, and we designed this some time ago, focusing on increased accrual to clinical trials, and we have to do outreach and reach the communities, so community engagement, develop partnerships with individuals and businesses, churches, and others where we have collaboration with influential individuals in the community, and also who can provide additional resources to patients. Then working with our basic scientists, our clinical scientists, behavioral and epidemiologic scientists, so that we've got everybody involved, and the 360 of healthcare, where we are first working with individuals in the community and trying to make sure that all of these processes are maximized, and therefore we can increase accrual to clinical trials, make available the right clinical trials to the right community at the right time. So with that, it is my privilege to go back to others on this panel and for all of us to work together with our organizations to deliver care to individuals. And healthcare does involve preventive strategies. So we need to prevent some of these cancers, give the right information to people, make sure that we have our 360-degree effort in providing these services to patients, and both from prevention to early diagnosis to best treatment and clinical trials, and then clinical trials on follow-up and survivorship. So thank you very much for inviting me to be a part of this panel today. It is my pleasure and privilege.
Thanks so much, Dr. Mitchell. We're really happy to have you. And thanks so much for setting the stage for all of us here and getting a lot of really crucial information to help us understand the context of really how do we increase that access? How do we engage with people of many different communities in clinical trials and colorectal cancer care? Thank you so much. Just a reminder, all of you out there, please, if you have any questions, to add them into the Q&A section or the chat at the bottom. If we don't get to all the questions today, we can always follow up with the speakers as well. Next up, we'll have Dr. Ramirez. Are you ready? I can go ahead and pull up.
Sure, that'd be great. Thank you so much.
You're
I appreciate it, Mike.
You got it.
And again, Dr. Mitchell, thank you for an excellent presentation and putting all of this in context. And my presentation was going to focus more kind of on Latinos and on clinical trials. So I'm ready to start. There we go. Again, my name's Amelie Ramirez, and I'm here at UT Health San Antonio, and I've been working with the Latino community for a number of years now. And on the next slide, Mike is going to forward them for me. I just wanted to share with you that Latinos now, or Hispanics as we were first called, and now it's Latinos, Latinx, represent 18.5% of the US population, and we have now become the largest minority population. And just a few years ago, cancer also became the leading cause of death for Latinos, and greater than cardiovascular disease. That is kind of like the #1 killer in the United States. But and so that has created quite a bit of fear in our community, and projections are that cancer cases are going to increase by 142% by 2030. And the next slide is just shares with you that colorectal cancer is the third leading cause of death among Latinos. And I work in South Texas in 38 counties. And in doing our homework here, we have found that we have higher colorectal cancer rates in South Texas compared to Texas and the nation. So this is extremely concerning for us. And as you just heard from Dr. Mitchell, the most concerning fact is that these rates are occurring earlier and earlier. And most folks don't tell their physician if they've had a family history of colorectal cancer in their families. And this is something that we're really trying to encourage our communities to talk about more. But just as breast cancer was 30 years ago, nobody talked about it, colorectal is kind of in that same situation. So we need to do a much better job. And on the next slide, I just wanted to share that the only way we can get the most effective treatments, although we have good treatments now for colorectal. Screening is a critical issue. We need to get more people screened and get them screened earlier. But we still find that Latinos are not participating in clinical trials as they should. Again, representing over 18% of the US population, and in some trials, they're about 10% represented, but in FDA trials where new treatments are developed and drugs are developed, less than 4% of their clinical trial participants are of Latino descent. The next slide shares with you a little bit about what are some of the barriers to participating in clinical trials based on a study that we conducted. And most of all, there's just a lack of awareness about trials. There's a lack of knowledge about why it's important to participate in trials. There's that whole issue of I don't want to be a guinea pig is still very, very strong. And we're hearing quite a bit of that as we develop the new COVID vaccines and so forth. A lot of people didn't want to participate because of that. But then we have other issues that has also been mentioned by Dr. Mitchell in terms of there's language, there's culture, there's just literacy issues that impact the opportunity to participate in trials. And then that in the Latino community, a large proportion of our community does not have good health insurance. And so therefore, a lot of the preliminary tests that are needed to decide if you can participate in a trial or not, they're disqualified because they don't have the resources to pay for those initial costs that are associated with a trial. And oftentimes the travel distance make it difficult. But when we did find out from the community is that if that would enable them and encourage them more to participate, if they trusted their doctor, if they trusted the center with which they would be participating in the trial and most of all, if they felt they were joining a trial that truly gave them hope for themselves and also an opportunity to contribute to the future patients. And then having it explained to them in a very clear format, and most of all, that they were inclusive of their family members in these discussions. So on the next slide, I'd like to share with you a study that we did. Even though it was designed for breast cancer patients, I feel that this is something that we can do and expand for to educate our colorectal patients about participating in clinical trials. The name of the program was called Choices. It included an online videos as well as a booklet talking about clinical trials, and also combined the access to having a patient navigator to help these individuals if they had any specific questions. The intervention itself really focused on increasing knowledge and attitudes about clinical trials and increasing the self-efficacy of the individual patient, that they could make an informed decision, and also encourage the types of questions that the patient could discuss with their doctors. As Dr. Mitchell said, that discussion and interaction with the physician is really critical as we talk about clinical trials. The individuals who were able to participate in this study were those individuals who attended our breast cancer clinic and had not had a doctor consultation just yet to see what treatment options were going to be available for them, that they had not participated in a trial, and that they would be willing to consider participation in a trial. On the next slide here, I just wanted to share with you kind of our research design. We reached out to 112 patients, and then we randomly assigned them based on an assessment that we did prior to the intervention. And then once there was a control group, and then the intervention group was divided into three different areas. One is they had never heard about a clinical trial. Another one is that they had some information. We were kind of basing it on the stages of change here, that they had heard about it, but had not participated. And the third one was that they understood what clinical trials were, but again, had not actually participated in a trial. And once they went through our program talked about what were trials, what was randomization, how do you make a decision, really what's best for you, so that we could answer before they met with the physician a lot of information about what clinical trials are. And then they would visit with the doctor, and if a trial was offered to them, they had the necessary information for that. On the next slide, what we found, it was that we were definitely able to increase their perceived understanding of clinical trials, their increased consideration that clinical trials could be a treatment option for them, and most of all, that they showed, the greatest stages of change. They went from kind of pre-contemplation to a contemplation stage, and that they were more likely to ask doctors questions about clinical trials, to discuss this with their families and friends, and also were able to weigh the pros and cons of participating in a clinical trial. And on the next slide, some of the lessons that we learned from this particular study is that just not raising awareness is enough to overcome some of the barriers for participation. And that barriers to participation are complex and very multifaceted. Again, as Dr. Mitchell mentioned, our healthcare system is complex, and our individuals are coming from different points of entrance into the healthcare system. So we really need to look at that system, that provider, and then the interaction that the provider has with the patient. And that most of all, the patient navigator was critical, because the patient sometimes felt more at ease asking someone that kind of looked like themselves questions about issues that they might not have understood in discussion with the doctor or with the nurse. So we felt that adding a patient navigator to make them available to discussing clinical trials was very important. And so the next slide, some additional lessons learned is that the population really wants to be involved in this, and that pre-testing was critical. You know, asking ahead of time how to design the program, and that we were making sure that we were answering the questions that the patients were interested in, and that an empowering intervention, such as the choices that we develop, can really enhance the patient's awareness and their self-efficacy to foster that sense of control, and that they felt that they understood the subject matter, that they could dialogue in a logical way with the physician, and most of all, that they were making an informed decision about what was the best treatment option for themselves. And then the next slide really shows that that our computer-based program was an effective strategy to increase our patients' knowledge and understanding of clinical trials, and to promote their participation in clinical trials. So, so this was a very comprehensive pilot study that we designed. It was supported through the Susan G. Komen Foundation, but it shared with us that this was possible, and that we feel that this can be tweaked to work for different types of cancers, and that we can help others, for example, with colorectal cancer. On this next slide, we also wanted to do some outreach work. On the next slide. It was called a clinical trials outreach manual for reaching Latinos. And what we wanted to do here is, oftentimes it's really hard to find the right time to talk about clinical trials if that's not a top of mind issue. And most of all, because of the fear in our communities about being told they have cancer, they really kind of parked that idea. So we did a comprehensive outreach program in which we went out to different community organizations, talked about clinical trials, increased their participation in, with cultural competency, how to actually start those trials. So this is a manual that we have available on our website. If anybody would like to access it, they are more than welcome to. And now I'd like to just transition just a little bit into some other work that we're doing. And again, I loved, Dr. Mitchell, I loved your slides with the apple trees. You know, that number one, we need to develop a kinder system, a kinder community. We are, you know, the things that just happened yesterday that have happened this past year, in addition to the pandemic, really shows that we need to really change how we care for people. And, you know, racial and ethnic discrimination continues to impact our health, our education, and just a number of other areas that keep many of our communities of color from being able to make significant progress. And so it's really important that we begin to look at how we can change this. And it starts at a very early age. We need to start really developing a more caring system at a very young age with our children. And our children of color, Black, Latinos, have really experienced quite a bit of systemic racism. On the next slide, I also wanted to highlight that many Latinos of color say that they've experienced discrimination due to their race or ethnicity from time to time, you know, and these numbers are just something that we need to really think about and how we can change that. And of course, even when Latinos are able to access a healthcare system and clinical trials, they continue to face biases sometimes from the providers. The provider may decide, you know what, this person lacks insurance. I'm not sure they're going to be able to get to the trial on time, or they'll be consistent. So oftentimes assessments about if they participate in a trial or not are made even before they've had a chance to discuss and be given the option of participating in a clinical trial. And on the next slide, I think it's really important for us to work together to create a greater cohesive culture for health equity. If we all work together, we can change, you know, and make it a better opportunity for the future. So this is just something that we need to continue to push for and work together to make sure that we accomplish this. One of the things that we've been doing through our Salud America program on the next slide is that we felt it was important to get people to reflect, to find out, do we have any implicit biases that we're not aware of? And there's a very simplistic test that we can take to see if we are harboring some biases that we need to change. And so we developed an action pack to help identify frequently asked questions, how to guide you through taking the IAT test and reflecting on what some of those results tell you, and also to provide some technical support. So really encourage you to go to our website and find out if you have implicit biases and what you can do next. And check this out. This is just, again, becoming more of self-awareness for all of us. And on the next slide, we also felt it was important to take action and to identify racism as a public health crisis. It is in all our healthcare systems. And again, we want to change that because our healthcare system should represent a truly caring environment, and we should embrace everyone. So this is something that we need to work towards. We are working with the American Public Health Associations and other groups to make this known. We're working with different states. Again, we've come up with an action pack that those of us in our communities, where we don't want people to forget what COVID has shined the light on and all the inequities that really were brought forth due to COVID. So we want to make sure that our communities establish task forces that are going to continue to focus on the importance of reducing racism in their communities and making our communities a more accessible and a welcoming place for all. So again, encourage you to come and get your action pack through Salud America. And then the other slide that I'd like to share with you, we are delighted to have been selected by Genentech. We are one of 16 projects that they funded on their Health Equity and Innovation Fund. In particular, our Genentech study will be focusing on creating Latino-focused recruitment strategies and ways of how we can impact the system to encourage more individuals to participate in clinical trials, not only for cancer, and that's all cancers, but also for Alzheimer's disease. And on the next slide, our specific aims of the program are to improve the Latino understanding of clinical trials and the need for biobanking so that we can develop future drugs that be effective for our communities, to how we can increase their self and collective efficacy for enrolling in clinical trials, and also how to increase awareness of the unconscious bias and discrimination that might be going on with our physicians. And so how can we curtail that and educate them about making sure that they equitably offer clinical trials to all. So the last slide is I just really want to thank everybody for this opportunity to participate. These are the team members that work with me on this subject matter, but we have a lot of work to do. And I look forward to working with all of you to truly creating a more cohesive culture in which everybody can benefit. Thank you so much.
All right, thank you so much, Dr. Ramirez. Really appreciate your presentation and your insights specifically to how your organization and your efforts as well are able to continue to support this effort. So thank you so much for being here. And finally, we'll have Wyatt, which will really help contextualize all of this information and look more specifically at some stories and some instances in which we can really look at focusing in and applying what we learn here about the inequities of access to clinical trials and how we look at some specific population examples of where it's been effective in overcoming those barriers. So thank you so much, Wyatt. You should be able to take it away.
Good afternoon again, everyone. I greatly appreciate the opportunity to participate in this webinar and talk about the access to clinical trials for American Indians and Alaska Native communities. I want to start by talking about, the understandings and perspectives of the world as an Indigenous person. At ACAF, we understand the need to assess our ways of life as Indigenous people when starting any new initiative. Our worldview as Indigenous people has always been nonlinear when compared to the Western worldview. And so the Indigenous worldview is about interrelatedness, balance, and sustainability. Lifeways are rooted in culture and grounded in respect for all living things. Indigenous people are often collective in nature versus individualistic, and collective culture emphasizes family and work group goals above individual needs, where individualism emphasizes personal achievement. Strengthening this connection creates opportunities for us to be healthier as Indigenous people, and we use this worldview to guide our work. And so I started here, really for that reason, because our work really does need to be grounded in the values and traditions of the communities that we work with. So here are a list of some potential barriers to participating in clinical trials research. And I was really excited to hear from Dr. Edith Mitchell and Dr. Ramirez on, some of what they had to say, because there is so much overlap in some of the things that I think a lot of our communities are experiencing, and some of that, access to participation. We can start in looking at some of those more, those individual barriers that, you would think are kind of limiting that access. And those really kind of start more at the top there with that awareness and education, eligibility, transportation, and resources. And when I think about that, even as we start to potential participants into some of that, thinking about clinical trials that relate to treatment and care, there's so many of our relatives who, never really even make it there. There's more of the barriers to screenings and prevention and the clinic systems that are going on, where even the eligibility of being able to participate in a clinical trial on treatment or care, there's not a lot of that's happening. There's so much more focus on, just trying to keep our relatives alive and like providing the support and resources for them. And then, of course, we get into topics of like that interest and capacity. Someone that may be going through an experience with cancer, participating in a clinical trial might not be at the top of their list. They might have more or other responsibilities to their family and community that are, up there. So there's some of that. And then again, the relevance and impact, what that participant means for them and their community, making that more meaningful is, or if it's that impact is going to be more general or broad and it's not specific to them as an individual or their community or family. And then of course the patient provider relationship and interaction, which I believe there were some of mentioned in some of the other presentations as well. what are those conversations that are happening between the patient and provider and what those interactions look like? Because if you don't have a strong relationship with your provider and access to some of that information, and again, going back up to that communication on the education, awareness, eligibility, transportation, and resources, if that interaction and relationship isn't well established, then it's going to really kind of limit a lot of that entry into those clinical trials. And then again, going back to the history of healthcare research, treaty rights, there's this whole history of what research in general has looked like within American Indian, Alaska Native communities, as well as many other indigenous populations, the reasons behind that research, who it benefits, and how. There's just so much research that's done from non-Native individuals or non-Indigenous people who are from outside of the community and looking to gain more than what's being put back into the community where the information is being collected from. There are also, 500 and roughly 74 Indigenous or American Indian, 574 federally recognized sovereign nations that all have their own unique cultural values, protocols, and practices. And so some of those things may influence their decision to participate or not. And so it's important to have those conversations and discussions with those communities to understand what their specific barriers in relation to those values, protocols, and practices are. And that has a lot to do with that cultural sensitivity and responsiveness in how the information and data is used and treated, especially if it is involving biological samples. So those are some lists or some potential barriers there. And so in terms of what can be done to promote clinical trials, trial access, let me go to the next slide, is to, really partner with Indigenous-led community-oriented organizations that do this work and can facilitate those partnerships and collaborations, because it can't just be a one-off project or a one, entry point, and then you get the information and data that you need, and then that's the end of it. It really does need to be these long-standing collaborations and partnerships. And so at ACAF, we really do have a mission to eliminate cancer burdens on American Indian families through that education, improved access to prevention, early detection, treatment, and survivor support. This is a critical part of the process, because it's, all of this knowledge and information that we have in the work we do at ACAF, a lot of it isn't something that can just be learned in a training or a webinar or educational program. It really does have to be understood through the lived experience. It's a way of life. And my knowledge on this topic and all of the work that I do is really grounded in my lived experience and the values and traditions of my family and my community. So at ACAF, we believe Indigenous communities have the knowledge to identify and develop the solutions to the problems that they're faced with. And oftentimes they're just looking for that support to make those solutions a reality. We need to go to the communities that we're interested in working with and really identify what their needs and wants and priorities are, and then help cultivate those relationships so that we can develop good solutions that are going to work for them. So that kind of leads me to building trust and engagement. Things that you can do is really, we get this question a lot, is like, what specifically can we do to help increase this potential? We need to invest in those communities. The communities and populations themselves need the resources. Again, they have those solutions, they have that knowledge, they just need the resources and support to do so. And so that also means establishing those long-term relationships, because at the end of the day, when a project is done, the community is going to still continue to be there, going through this, regardless if there's a project or funding in place. And that's where ACAF comes in, and we establish those long-term relationships to pull in those resources and continue those relationships in multiple different projects, because it can't just be one thing. It has to be a whole system of things that work together. And really centering those needs and priorities of the community. Too often it's non-native or non-Indigenous researchers coming in, hoping to work with a community on an already identified topic. And if that's not going to go over well, if the community is like, that's not a priority for us. There's so many other things going on in the community that sometimes that's not where they're at. And we really need to meet the community where they're at and what they want to focus on first. And then figuring out how we can work together to address some of the other things going on. And so then those solutions need to be tribally led, community-based, and rooted in that culture, like I was talking about, and then providing that continual support and resources, because there's, as many people in research know, there's a lot of other factors that come into play, and a lot of things that happen outside of that plan, and you have to be able to adapt and be flexible in a lot of that work. Because again, there's a lot going on in the communities that you might not be aware of, and so being willing to do that and be flexible is important. Really kind of just asking for what they need and not what you want from them. So I touched on cultural responsiveness and humility a little earlier. And so, again, this is where it's so important to center those Indigenous communities, their wants, their needs, their priorities. The communities that are involved also need to have that authority and decision-making power in the projects that they're involved in. I mentioned the federally recognized tribes within the country. A lot of those tribes have treaty rights, and they have tribal sovereignty. They have the decisions to make, or they have the power to and authority to make the decisions for their themselves. And so that data and information that's collected is really important to be able to say, this is your data and information, and how would you like to use it versus, we're going to collect the data and take it and use it in the way that makes sense to us and benefits us outside of the community. And so that's so important to recognize and honor. Having data sharing agreements, data ownership agreements, outlining what those processes are and what those expectations are really important to have up front in those discussions. And then, of course, the one of the most important things in general is to be an advocate, an ally, a partner, in recognizing that you can't be having that savior kind of mentality. Our communities have existed and survived for hundreds and thousands of years. And so again, they have that knowledge and wisdom. We need to be able to support them and honor their traditions, values, and systems and ways of knowing. And so I think I'll end by saying, that we're all here working together to create positive change and promote healthy norms for our communities, including, that work to promote participation in clinical trials for American Indians, Alaska Natives, and Indigenous communities. Thank you all very much.
Great. Thank you so much, Wyatt. Really appreciate that, and really appreciate the level of detail there as well, getting into some specific, practical ways that we can address these barriers, which actually brings us into our first question. And this is really open to both Wyatt and Dr. Mitchell, if she's available. But just looking at that, some of the information presented here is more or less common knowledge within the field of research. and wanting to look a little bit deeper into, can overcoming the barriers to enrolling unique populations for researchers, aside from personal awareness of racial inequities, be accomplished through different practical things. So I think you mentioned a lot of examples in there. I certainly was able to pull out, as I was listening, thinking about bringing in, within the planning phase, the communities that you're serving and making sure that their voice is heard in the initial construct of how you're going to connect and engage with people, as well as from Dr. Ramirez's presentation, talking about engaging the liaison healthcare members like patient navigators and community health workers that know what's going on and have a connection with those specific communities. Do you have any other examples specific for researchers where they can really use practical things to apply to overcome some of these barriers?
Yeah, I mean, I think that's what's really hard to say, like some of those practical pieces, because it looks so differently for every community. There's some projects that we have at ACAF here that we partner with, some communities at within our region, and some that are next door to each other, and they have very different access to resources and information and different kinds of support. And so, it could be the same project, but the way that it's implemented and carried out could look very differently based on those things. So really, it's going into that community and establishing that relationship and getting to know them and understanding what those needs are. So I wish, I could say you have to do X, Y, and Z, but really it's laying that groundwork and understanding what the community needs, and they have to be the ones to provide that information. It can't, again, be this straightforward, like, here's step 1, 2, and 3. It's going through and establishing that relationship.
Right, exactly. Yeah, thanks so much. Now, I got a couple more questions for you here that have come in as well. We have one is, can you please comment that Native Americans have a birthright to insurance in the US? They're the only population that this person is aware of with that condition, and yet they are the least treated. The question is, how can we leverage this available resource to better improve health outcomes?
Yeah, so to clarify a little bit, those birthrights really are tied back to our treaty rights, which there are, several different treaties. Each, there's not one single kind of governing document. Different communities are included in different treaties, and there's different rights associated with those. Many of those include, that right to healthcare, and while that's the case, you still have to get that healthcare through the Indian Health Service, which unfortunately is incredibly underfunded, and the care that's provided to the communities is always is not up to par to meeting those needs of the communities. Oftentimes, our relatives will go to get care, and the funding has run out for the year. And then it's like, what do you do? Like, so what's the point of getting a screening or a diagnosis? And because if there's not going to be any follow-up care available, then that just puts you in a really difficult situation. And so, I think it's really hard to leverage that. And because a lot of our communities have already been, pushing for increased funding because of those treaty rights. And so, we've been doing that, but having that discussion with the federal government is always a challenge. Just like, I think it's a big conversation on, Medicaid and Medicare, trying to increase the funding for that. So it's like, how do you balance some of that? And so that's why we try to go in and support the communities with supplemental funding as well, because we know that this has been a longstanding issue to get IHS funded at a level that's appropriate.
Okay, great. Yeah, thank you. And it sounds, is there a way that the pharmaceutical industry can perhaps help with encouraging the support?
Yeah, I think so. Again, it's really kind of partnering with those like organizations like ACAF that, know and understand what these communities look like. We're not the only, organization. There's many other institutions that partner with these communities and doing the work to that meet their needs. And so as long as those relationships are approached, with a good mind and heart, and centering the needs and priorities of those communities. I think that there's certainly the opportunity for collaborations and the ability for those entities to kind of support this work.
Great. And then another question coming in, is going to a cancer center an issue for the American Indian population? Do they need those resources brought to them?
Absolutely. Like, geography, I think, plays a big role in what that access looks like. Transportation can be a huge issue for, really anyone in rural areas. And so, bringing some of that care into the community, and as long as, again, if that's how they want to approach that barrier, then I think that would be fantastic. Trying to provide screening and support and services in the community is always a nice thing. So, and also just like going, outside of your community into a whole new like building or system that's unfamiliar to you, that, could still have a lot of the other issues that Dr. Mitchell and Dr. Ramirez were talking about in terms of, racism, equity, all of these other issues that oftentimes, many of our communities have experienced for generations, makes them hesitant to go into those spaces if that trust and relationship isn't established already.
Great, thank you. And then one final question here. You had mentioned tissue collection and removal as a barrier. Do you have any insights on how we can perhaps overcome that?
Again, it's going to go back to the individual communities. The community that I come from is going to have a certain perspective and view on that. And there's even, uniqueness within communities. Each family kind of has, their own perspectives on it. And so it's just talking through like what's appropriate, how can we do this, and working through those in on that kind of individual case-by-case basis, and making sure that those tissue samples are collected for the right reasons, that they're used for the right reasons, that they're just handled, and maybe it's being that they need to be given back to the individual or the community. Those are all things that you typically wouldn't consider, but could be very important things to a specific community.
Great, thank you so much. I appreciate you staying a little long to get those questions answered and everything. We had a lot of information to go over today. And thank you out there to all of you attending right now who have stayed a little extra to get this information. We hope that it's been very helpful for you as well. So I just want to thank Wyatt again, of course, and thank Dr. Mitchell and Dr. Ramirez. And also thank you to our sponsors for this clinical trial education, No Shave November, Genentech, Merck, Taiho Oncology, and Bristol Myers Squibb. So thank you to them. Thank you to you. This has been great, and we hope to see you next month for our next webinar. And again, if you have any other additional questions, you can reach out to us at Fight CRC. We'll get them in the right direction. This webinar will be archived if you want to watch it again. And there's plenty of other resources where this came from at fightcrc.org. Take care, everybody. Have a good one.